So David is British Heart Foundation and Duke of Edinburgh Chair and a Professor of Cardiology at the University of Edinburgh. He has major interests in experimental medicine and the advanced imaging of cardiovascular disease, including coronary artery, aortic stenosis and heart failure. So looking forward to your talk.
Thanks, Juliana, and thanks very much for asking me to come and speak today, particularly as a cardiologist. So you've got to be nice to me with any kind of really complicated nuclear medicine questions. But what I thought I'd do is perhaps to complement Sam's talk quite well, I think, is focus a little bit on the clinical aspects of some of the things that I'm doing, hence the title. But I'm not going to stand here and just talk about the heart, so hopefully I can also engage you in some other applications extrapolated from some of our experiences to date. And obviously, as Sam's already alluded to, theirs is going in the summer, ours is going in the autumn. So I haven't got anything I can really tell you about total body PET that Danny's not already alluded to, having not actually got the scanner in and switched on. So what I thought I'd do, first of all, is go through a little bit of duplication, perhaps, but just the why, the where are we setting ours up, and then perhaps some of the applications as I see it as it's coming through. So first of all, there are two currently available ones. There are other manufacturers that are obviously looking to produce total body platforms as well. Obviously, the United Imaging Scanner, unless you're an Aborigine or a Nordic god, will cover the whole body at 1.9 meters. And obviously, the SIM scanner is slightly smaller, but nevertheless, will cover all the major organs, etc. These things do lead to some potential differences, I suppose. The purists will like the longer the better. Of course, if you're a purist, you want a spherical PET scanner with a body in the middle of it, spinning around it perhaps, I don't know. But obviously you're going to get more, and you know, Siemens have bolted 3 or 4 scanners together, 4 or 5 scanners together, United Imaging 8 scanners together to get the full body coverage. Of course, there are some practical issues. If you've got a very long tunnel, actually getting access to a vein can be quite challenging, and putting it in your foot to do things sometimes as it's poking out, etc., or the arms way above your head or whatever, and access to the patient can sometimes. But essentially, these are the two commercially available ones, both generating masses of data because of all the coincidences, etc., that's coming out. So why are we getting so excited about total body PET? Well, I suppose that there are so many potential things that really bring it out. As already alluded to, the wide field of view, simultaneous imaging. The fact that you've got so much sensitivity means you can get down to ultra low dose, and that opens the door to some of the traces that Sam was already alluding to in terms of zirconium traces. Some of the things that excite me as a cardiologist is the higher sensitivity, so that we can actually get down and start looking at coronary arteries and really small structures in better detail. It does allow multi-tracer imaging, so we can do deconvolution of different traces at the same time, doing also systemic network analysis, looking at how different organs uptake times and how they interdigitate in health and disease. And obviously, as already alluded to, let's start imaging newer populations where PET has not been perhaps as relevant, and I'll perhaps give some examples of where that might be. So that's just the headline figures of why we're all so excited about total body PET. And as you know, as Sam's already alluded to, the MPIT platform funded 2, although Royal Free were always ahead of the game and more visionary and got theirs in as well. So NPIP now has potentially 3 centres that are going to be interdigitated in the platform. So where's the one in Scotland going? Well, it's going here, the little France site in Edinburgh where I work, which provides tertiary services for the southeast of Scotland. Our imaging centre is already situated in the basement of the Queen's Medical Research Institute, and I'll show you some plans of that in a minute. But we also have a scanner in the hospital as well, an MRI scanner, which is situated directly next to the emergency department there. In our imaging centre, we have PET-MR, PET-CT, MRI, and obviously later this year, total body PET, and in the new year, hopefully a photon counting CT as well. But that's the clinical scanners. We also, with Adriana Tavares, who leads our preclinical facility, we do have 3 PET scanners for small animal work, 2 PET CTs and a PET MRI, as well as a 9 Tesla animal MRI scanner. So lots of preclinical facilities, which I think is really important for a program like this, to have ready access to the preclinical and the clinical to really enable you to translate rapidly. And in part of that translation comes with having clinical research facilities for the patients to come through before they go through into their imaging, which is MHRA accredited, so we can do early phase 1 work and develop novel tracers. And if you're getting into big clinical trials, there's also our clinical trials unit up on the hill. So we think this is a great opportunity. I want to flag up that this is the Scottish scanner. We work very closely with Glasgow. David Lewis led the Glasgow arm, and their focus is very much on the radiotracer development. So they've got some fabulous chemists, which we collaborate with already, even before the bid, producing novel radiotracers and getting into humans. And we have got a TSPO tracer, which is going to humans this year, with Adriana working very closely with David and the team, and Andrew Sutherland in Glasgow. So hopefully we've got all the kit, the right place, the full spectrum of translational imaging supported by novel radiochemistry production. So in the basement of the QMRI is our imaging centre, and as I alluded to, we do have a suite of scanners down there. We are going to obviously take out our 15-year-old MCT scanner and replace it with our total body PET scanner. We do have O15 water capability, which is pumped from our cyclotron through a trench to the total body PET scanner. So we have done O15 perfusion imaging. We're upscaling to do more carbon 11 because we haven't done much to date, certainly in the clinical arena anyway. And obviously that's again a great strength for the total body PET scanner. And we have recently upgraded our radiochemistry suite to 11 hot cells with several of them which are GMP compliant. And indeed, because of the network that we have with Edinburgh and Glasgow, Glasgow also has a cyclotron and GMP hot cells. Newcastle doesn't have a cyclotron but does have some hot cells that they've recently developed. So we ship them some radionucleotides for them to do radionuclide F18 mostly at the moment. But we are sharing with them some of those so that they can generate their own radio tracers locally and hopefully ship some of them back too, spreading some of the work that they're looking at with neuroimaging and neuroscience. So hopefully I do want to reiterate what Sam said, that this is a national facility. We want people to be applying to use our facility. We have well-worked schemes for doing it. We do lots of imaging across Scotland and the north of England. We already do scans for Newcastle and sometimes even down to Manchester. So very keen to collaborate as the north part of the UK. So that's the why and the where. What we're going to do with it all? Well, I suppose from my perspective, some of the things I'm going to come back to the heart now, because that's where my comfort zone is. But we've used various tracers over the years in orthodox PET scanning to look at calcification, thrombosis, fibrosis, inflammation, angiogenesis, all key processes in the pathophysiology of cardiovascular disease. We could argue that those processes are very germane to many disease areas, including cancer, but also neuroscience, respiratory, GI, even obstetrics and gynecology. So some of the work that we've done, particularly with the support of life molecular imaging, has been looking at thrombus, because thrombosis is a main driver of most cardiovascular diseases. And we use 18FGP1, as I say, in collaboration with life molecular imaging. And it's a tracer which binds to activated platelets. So glycoprotein 2B3A receptor on platelets, and it's not just like any glycoprotein 2B3A receptor, which you might not know if you're a cardiologist, but there's a whole raft of therapeutic inhibitors and antagonists of that receptor on platelets. It basically is the receptor that allows platelets to hold hold hands and aggregate. But those most inhibitors block it irrespective of the activation state of the receptor. But GP1 actually is based on L-lorifibin, which is only binds to the glycoprotein 2B3A receptor when it's activated, when it's in an activated state. So the platelets are wound up. And so it's a really neat tracer to look at active thrombosis. And this is some work that Beth Whittington, who's one of my PhD students working with me, did in stroke patients. And this patient, hopefully you can appreciate, I'm going to point at this one since it's the nearest one here. But this patient here had a middle cerebral artery occlusion here, you can see here, pre and post thrombectomy. And this was the GP1 study that we performed. We could see that actually the clot had come from the left atrial appendage. And it actually did also light up the infarct, because you get a lot of hemorrhage, petechial hemorrhage into the infarct. But actually you could even see the site where the thrombectomy had taken the clot out. Obviously there's some residual thrombus there. On the far right here, you can actually see an example of GP1 in a Korean group's study of patients with pulmonary embolism. I show this because obviously they did multiple scans all the way down the body, and this is obviously what total body PET can potentially offer to you. This patient actually collapsed and shows the power again of the tracer, in that you could see where the pulmonary emboli had come from. The left leg DVT had broken off and caused a bilateral saddle emboli. But you can also see that they bashed their knee, they broke their jaw, and they cracked their chin when they collapsed. So it really is quite an impressive tracer. But on top of that, of course, we have things for stroke, for example, of cryptogenic stroke. Where's it arisen from? Is that PFO the cause of the stroke? And we spend a lot of time closing PFOs with uncertain, to my mind anyway, conclusive evidence. Well, if we had a technique which could do total body PET, look for clot in your legs, see if that PFO is not just an innocent bystander, but actually there was a clot in the leg that flew off, flipped over, and caused a stroke, then it would be worth closing that. And so there are lots of opportunities, I think, to try and work through that. We're now at around 50 or so patients. We're hoping to do more once we get the total body PET scanner, to really try and work out the causes and the origins of thrombosis and cryptogenic stroke, which is a huge problem in the stroke community. A large proportion of patients don't know have a cause of stroke, and it's always assumed to be AF, and it often is. But actually, there's an awful lot of patients with strokes who are in AF who don't have any clot in their atrial appendage that we can see. And I think often it's something else, and we've seen several examples where clot is from the aortic arch, the vertebral artery, other regions where you weren't expecting the clot to come from. So I think this is, again, where a wide field of view scanner that's going to cover the brain and the heart and the major vasculature is really going to be quite powerful. Coming back to, or closer to my domain, we've also done this in acute myocardial infarction. Of course, coronary structures are 3 millimeters in diameter, 4, sometimes 5 if you're lucky. So at the resolution of PET, and so quantitatively you're getting to partial voluming. But when you're looking for, does it exist, is it present, yes or no, then perhaps the quantitative elements are less important. But as you can see here, we've done this in around 50 patients with myocardial infarction. You can see this patient's got horrific coronary disease, and you'd be hard-pressed to know which lesion had actually caused the myocardial infarction. And yet when we looked at the PET, we could see it was in that right coronary artery, quite an intense uptake, whereas the other vessels were free of disease. And certainly when we looked at this, as I say, in people with infarction, those with infarction but the non-culprit vessels, and patients with cardiovascular disease and coronary disease who didn't have an infarct, you can see it's quite discriminatory, and in fact was 100% specific, but did lose some sensitivity. I think that's partly because number one, sometimes we couldn't quite image them quick enough. Obviously the patients are on antithrombotic agents, and I think there's some dissolution. But I also think we overcall, just because we see a severe stenosis, we assume it's a thrombotic occlusion. And actually, I think a lot of the patients that we're treating have myocardial infarction because of critical stenoses and what we call a type 2 MI. I won't bore you with the details, but I think there actually isn't a thrombus there. So I think this is really telling us a lot more about the pathophysiology of the disease. Is that esoterically interesting, David, or does it have any clinical applications? So I just thought I'd show you one example. This is a patient that I think I got out of bed at 2 in the morning to treat with an ST elevation myocardial infarction. The circumflex was occluded, passed the wire through, and you can see that the contrast isn't necessarily as straightforward as it could have been. But I put a little stent in there, or a big stent, and I said to my fellow that you should really image this person because they had such a high thrombotic burden when I did the angioplasty. And here you go, the still image, the high resolution image, you can just see a filling defect here. And I did put a stent in it. You can see it on the CT coronary angiogram here, the red arrow. And of course the thrombus is trapped behind that stent because it won't dissolve instantaneously. But what I hadn't quite expected was that the atrial appendage also lit up. And this is, you probably can't appreciate it, but the patient was in normal sinus rhythm. On my ward round later that day, in the morning, the nurse told me he had a paroxysm of atrial fibrillation, which is not uncommon in patients after an MI, so I just shrugged my shoulders and said, well, I'll just keep an eye on it. But actually, after the PET scan, what I realized is this patient had paroxysmal atrial fibrillation that then embolized a clot that then landed in the circumflex artery. And so we changed our management based on that. So I then started my anticoagulation. So I think it is an example of where we can change what we do with this, and particularly with the high sensitivity that we're going to get from a total body PET. Really drilling down into that. We're going to be getting a lot more information, and we're going to expand this into an area called MINOCA, which means myocardial infarction without coronary obstruction. Changing traces a little bit. I'm sorry, I think this is about the last example I'm going to show of the heart before I move on to other areas. Mark Dweck in Edinburgh and I have been working, looking at fibrosis imaging. Mark has done a lot of work looking at T1 weighted imaging and magnetic resonance scanning, late gadolinium enhancement, and looking at extracellular volumes, etc. But very often when you have late gadolinium enhancement on a myocardial infarct, a scar, you don't know whether it's scarring or it's scarred. You don't know about the activity of what's going to happen next. So we've been exploring gallium FAPI, fibroblast activation protein inhibitor tracing to look at fibrosis activity. Obviously fibrosis and the tracer binds to activated fibroblasts. So these are cells that are obviously actively fibrosing the tissue. And the best example, of course, is a myocardial infarct. So you can see on the MRI here, these are PET-MR pictures that we have showing quite intense infarction here in the anteroseptum. Here an inferior one smiling at us, gadolinium enhancement and fibrosis. And this is all an acute myocardial infarction. And this is chronic myocardial infarction. We still see a very tiny little bit of a signal. And with a PhD student, Anna Barton, we've done a whole series of patients. Doing on PET-MR, of course, the radiation dose is that much lower. So you can do serial imaging and looking at the fibrosis activity. Now, classic teaching in cardiology is by 3 months, everything's done, your heart's healed, move on. But actually, it's still very active, healthy controls down here. You can see there's still an awful lot of activity. And some of these chronic infarcts are still showing activity many, many years later. And actually, if you plot time with fibrosis activity, it shows you that the heart is healing for many years after a heart attack. That fibrosis activity really goes away completely. So fibrosis, I think, we do need to follow that serially and scan repeatedly. And so again, a total body PET would allow us to look at this process chronically. PET-MR can do it very well, but again, it comes down to sensitivity and multi-organ tracing, which I think is going to be key. So in our centre, in our bid, we did highlight many different areas that we're particularly interested in, and some of these are in the cancer domain. Some are in paediatrics, so James Boardman, looking at prematurity, encephalopathy of prematurity, really very challenging circumstances, very sensitive area. James has actually done a lot of MRI in utero and in neonates, managing to feed them, or the mother feeds them before they put into the scanner and they're nodding off. So you can do that, but of course with a total body PET they can even wriggle a little bit and you'll still be able to hopefully get some good signals. And again, using ultra low doses is going to be key there. I'm going to come on to discuss some of the other areas. So David Lewis, as I said, in Glasgow, is very interested in cardiac cachexia, multi-system problem germane to all cancers. And there are many pathways that are potentially involved. So his idea is to look at the whole body's metabolism and the effect of cancer on that. And so a whole body approach is really going to be quite key. On top of that, we could potentially do multiple tracers, obviously, giving a short-acting and then a longer-acting, either simultaneously or spaced out, and depending on the kinetics, how that can be deconvoluted. That's going to take quite a bit of working through in terms of processing, and that's going to be the next challenging area to really get into, is to really explore that, how we can look at the network analysis, how different organs are behaving in this cachexic state associated with cancer, what are the pathways involved, how are they talking to each other. Another example that we're currently exploring is doing some work in endometriosis. As you may know and seen in the press not that long ago, it takes up an average of 8 years to diagnose a woman with this very painful, unpleasant condition of endometriosis, and often requires surgery to do a laparoscopy to find the lesions that cause it. But actually, we have two tracers that could potentially be very important to that. Acute endometriosis with hemorrhage and bleeding into the lesions into the peritoneum, which is the painful part of the initiation of it. So beautiful example for GP1, and we've seen that in ex vivo tissue. And of course, FAPI, as it starts to scar, we can then look at that. And of course, these are often women of childbearing potential who are anxious about any kind of radiation exposure. So again, we can go for low dose imaging here with these tracers to really minimize that and compare it to a day out in Aberdeen if you're in Scotland, or Cornwall, or wherever you are, if you can get that radiation level down. I suppose the other example I wanted to share with you was arteritis, large vessel arteritis. Neil Basu in Glasgow and Neeraj Dawn in Edinburgh, very keen and work very closely together from a rheumatological and autoimmune perspective and renal perspective, looking at cardiovascular disease. And again, the beauty of the zirconium tracers being able to look at all the different immunological pathways that we have. Again, this is a great example of where total body PET might come into its own, because you can look at all of those different things on a whole body wide field of view level, as well as use these tracers that we can use at much lower doses to minimize that radiation dose over days, and also response to immunotherapy. Hit them hard, has it dampened it down? Another very quick example, I think I'm running out of time a little bit here, aren't I? Rabbiting on. Here's one of the things that I speak with Peter Hayes, who's a professor of hepatology in Edinburgh, quite a lot. And it was nearly over 20 years ago, we came up with the idea of the Splanchnik-Steele syndrome to explain the cardiovascular effects of liver cirrhosis, because liver cirrhosis is well known to have a hyperdynamic circulation, and yet he kept telling me everyone's shut down, they're quite cold when you touch them, and actually he had a thermal camera image to prove it to me, and actually they go into renal failure, which behaves a bit like pre-renal failure. Why is that? And we came up with this idea of the Splanchnik-Steele syndrome, where the blood circulates more around your gut and everything else shuts down a little bit. You do have a high cardiac output because it's all whizzing around your gut because of the physiology or the pathophysiology of cirrhosis. We did send this to the Lancet, but they wouldn't take it because they said, you need to prove it. And of course, we have no technique to prove it. But now we've got a total body PET scanner, and I can use my O15 water trench to infuse it and look at tissue perfusion across the whole body simultaneously, and maybe yet to prove that this theory is right. We are also developing novel tracers for hepatocellular carcinoma with Tom Bird. Again, this is taking things from the very early stage into systems biology. We are doing a lot of work with David Lewis and Adriana Tavares looking at modelling, and Adriana's already been working on the MyoExplorers data, looking at modelling of multi-systems with collaboration with colleagues in Sacramento. So I think this is also going to be a big area that we're going to need to address. So I've probably running out of time, but that was the why, the where, and the what of our centre in Scotland. As Sam said, please come and talk to us. We'd love to do some studies with you. Thank you.
Yeah, so we're a little tight on time. If there is a burning question in the audience, if anyone wants to go up to the mic. Yeah, go on then, Danny. Yeah, thanks.
That was a great talk, very exciting talk. I mean, it's not really a question. It's really just what I picked from that was that with total body PET, we got to think again, in the sense that people have said, "Oh, look, we did PET, we tried PET on that, and it didn't quite work." And now you go, "Well, you got to think again." Total body gives you a completely different view of the world, and in terms of low dose as well, it allows you to do it on things to people that maybe people were nervous about doing, but also it gives you a different view of the world because of the total body and the parametric aspect. So I think your aspect, like endometritis, stuff like this, we could look at all these things again.
Yeah, I can't agree more, Danny. And I just, again, want to encourage people here today to think it through and come up with other challenging ideas and ways to use this, because I think it is potentially game-changing. So thank you.
Absolutely.